I'm Dr. Katz, I'm a non-invasive cardiologist, and today we're going to be talking about hypertrophic cardiomyopathy. A cardiomyopathy is simply a weakness of the heart muscle, and hypertrophic cardiomyopathy indicates that the underlying etiology or reason that that heart muscle is weak is because it is abnormally thick. Hypertrophic cardiomyopathy, at the root cause, is due to a genetic mutation. That genetic mutation can happen in the wild or in the general population, but it can also be inherited. In fact, hypertrophic cardiomyopathy is the #1 most common inherited cardiac genetic mutation. I won't get too far into the genetic details, but there are over 11 genetic mutations that are known to be culprits of hypertrophic cardiomyopathy. However, every patient can have different or varying degrees of expression of that phenotype, which simply means that every patient clinically can manifest their hypertrophic cardiomyopathy in different ways. For cardiology fellows, the two most common genetic mutations are MYH7, or the beta-myosin heavy chain, as well as the myosin-binding protein C. Hypertrophic cardiomyopathy can manifest clinically with a variety of different symptoms. It can cause patients to have chest pain or shortness of breath, in particular with exertion. It can cause lightheadedness, dizziness, or episodes of syncope or passing out, as well as palpitations or feeling like your heart is racing, as well as many arrhythmias or abnormal heart rhythms. Now, one of the reasons why I love cardiology is that it's a very visual field, and we can take a close look and actually see what this abnormality is. You don't have to be a cardiologist to know what you're looking at, maybe just a little bit of guidance of a cardiologist to interpret those echo images. To start out, let's take a look at the histological image of the actual abnormal muscle of the heart under a microscope. In these images, you can see myocardial fibril disarray. It's not just that these muscles are abnormally thick, but it's also that they're kind of thrown in a haphazard way. It causes the organization of the heart to not be similar to what a normal heart looks like, where all of those muscle proteins are neatly stacked. Instead, you got this disarray of fibers that can cause fibrosis, and fibrosis can lead to a lot of other abnormalities, weakness of the heart, and arrhythmias. Now, one of the ways that we might diagnose hypertrophic cardiomyopathy is through an abnormal EKG. On the screen here, you can see that this is an abnormal EKG. If you're a muggle or someone not in medicine, this might just look like squiggly lines. And even if you're a medical trainee, it might as well. My cat agrees. But here, let's compare it to a normal one. So on the left side of the screen, a normal EKG, and on the right-hand side of the screen is an EKG that would warrant an echocardiography or an ultrasound of the heart because it indicates left ventricular hypertrophy or a very thick heart. And this is kind of classic for HCM. And here, we're also going to see another EKG that is also indicative of HCM, but a different type of it. And I'll get into some echo images and pull them up to show you what these EKGs actually correlate with. Suffice to say, however, that if you see these very abnormal EKGs, it normally prompts healthcare workers who might not be in cardiology, might not be able to make that split diagnosis right away. Excuse me, I'm doing something here. Now let's take a look at an echo from these patients who had this abnormal EKG. So here on the right-hand side of the screen, you can see an echo or an ultrasound of the heart. She's not interested in. First, let's show you just a normal echo or ultrasound of the heart. Now she's interested. So first, let's take a look at what these abnormalities in the thickening of the heart look like on ultrasound, as well as MRI. And then we're going to get into what the abnormalities with the mitral valve and papillary muscles look like and why that can cause clinically significant symptoms. This is a normal heart on the left-hand side of your screen. And all you have to be able to see and recognize is that on the right-hand side of the screen, you have hypertrophic cardiomyopathy, where that middle portion or the interventricular septum is severely thickened. This is a different patient with hypertrophic cardiomyopathy that affects the basal portion of the interventricular septum. This is the left atrium, mitral valve, left ventricle. This is the thickened portion of the interventricular septum that separates the left ventricle from the right ventricle. This is the aortic valve, and then here is the aorta. Now I'm going to slow it down a little bit, and I just want you to focus on the mitral valve. And the top valve is the anterior mitral valve, and you should be able to see that it kind of kinks over, it kind of bends over, and that is the culprit of the hypertrophic obstructive portion of the cardiomyopathy, where blood literally isn't able to get out of the heart through that area, that left ventricular outflow tract, because the mitral valve can be abnormally elongated, where there's just extra mitral leaflet, and it kind of kinks over during systole or when the heart's beating. The mitral valve leaflets can also be inserted into the left ventricle at the wrong angle or just slightly off, and that abnormal geometry can make that mitral valve prone to causing obstruction. And then on top of that, this thickened septum also creates another nidus of a possible obstruction, that the heart muscle itself is so thick that it doesn't allow blood to get out of that left ventricular outflow. Now, since we're talking about the mitral valve and papillary muscles, I want to show you another interesting echo. This is of a patient who is gene positive for HCM, but on their echo, they didn't have abnormal thickening of the heart muscle, but they did have abnormal thickening of their papillary muscle. The papillary muscle connects to the mitral valve, helps it open and close. Here, you can see again that this is the bottom chamber of the left atrium, top chamber of the left ventricle, and that thing that's kind of running in the middle of the heart is the papillary muscle that is very thick. I mean, I assume you didn't even notice it in the other echoes I've showed you, appropriately so. This is quite abnormal and was actually causing obstruction in this patient. And here's a cardiac MRI of that same patient, and you can see how thickened this papillary muscle is. And again, that papillary muscle being abnormally thick because they were gene positive for HCM is why they were having HOCM, or hypertrophic obstructive cardiomyopathy, and the cause of their underlying symptoms. Now here's another echo that we can't really see much. So we used an echo image enhancer to light up the heart a little bit. And in these images, you can clearly see that the left ventricle's there, and the apex, or the tip of the heart, is really abnormal. Here's an MRI of that same patient, and you can see that this is an example of apical hypertrophic cardiomyopathy, where the apex, or the tip of the heart, is severely abnormal and thickened. This is one more video of an apical hypertrophic cardiomyopathy patient undergoing a left ventriculogram. Here you can see where the left ventricle is, and this is the pigtail catheter that's injecting dye into the left ventricle. And what I want you to see is that this is indicative of spade sign. Here's a still image showing that. On the left is in systole when the heart contracts, and on the right is when it's in diastole relaxing. And here's a much prettier picture, in my opinion, of an echo showing that same thing that we already saw earlier. But now next time you see this on an echo, you can go, that looks like spade sign, indicative of apical hypertrophic cardiomyopathy. One more cardiac MRI that I'll show you is another example of a different type of hypertrophic cardiomyopathy phenotype. This is concentric hypertrophic cardiomyopathy, where the entire ventricle is thick, out of proportion to what we would expect from any other clinical syndromes like hypertension or aortic stenosis. So far, we learned that there's hypertrophic cardiomyopathy that can classically affect the basal portion of the septum, apical hypertrophic cardiomyopathy that affects the tip of the ventricle, concentric hypertrophic cardiomyopathy that affects all of the ventricle, much more rare, as well as mitral valve abnormalities, abnormally elongated mitral valve leaflets, as well as abnormalities of the papillary muscles that can cause systolic anterior motion of the mitral valve, or SAM, which can lead to obstruction of the left ventricular outflow tract, or obstruction of blood from getting out of the ventricle. Patients can have one of these different variants along with abnormalities in the mitral valve. They can have mitral valve abnormalities in isolation, or something in between. And the way that we typically differentiate patients is that they either have HCM or HOCM. Both of them are hypertrophic cardiomyopathy, but one is without and one is with obstruction. Now, we've talked about EKG and echocardiographic findings that may be indicative of HCM, but a simple murmur on physical exam can also clue us in that maybe there's something else going on. So what does that murmur sound like? For patients, this might better help you understand why we make you get up and get down and try and lick your elbow or whatever. And for medical trainees, this is 100% going to be on any test that you take. What you should remember is that a murmur is simply turbulent blood flow, whether that's from a stenotic or very narrow valve, or from a very regurgitant or leaky valve, or for something else that's going on inside of the heart. If you were to take a garden hose and just turn it on to a normal amount of pressure, you shouldn't really hear that water flowing through the garden hose. But the second that you put your thumb over the top of that garden hose, you hear the turbulent blood flow. There shouldn't be blood in your garden hose. Similarly, if you have a valvular abnormality or HCM that blocks blood from exiting the left ventricle, it can manifest in a murmur. So what does the murmur of HCM sound like? The basic thing you have to remember in the murmur of HCM is that you want to avoid decreasing your preload or decreasing afterload in isolation. Both of those things are going to accentuate the murmur of HCM or make them louder. The reason that decreased preload or decreasing the amount of blood in the left ventricle is going to accentuate that murmur is that when there's less blood in the left ventricle, it is easier for that systolic anterior motion in the mitral valve to occur and for obstruction to occur, causing that murmur, or if it's already there, making it louder. And similarly, that abnormally thick muscle in the basal septum can push over a little bit more because the left ventricle isn't distended as much as it normally is, and can also worsen that obstruction and make the murmur of HCM louder. Now, afterload is the pressure with which the heart has to pump against, kind of like your blood pressure. Decreasing afterload increases cardiac output by increasing the stroke volume and vigor with which the heart is able to pump. When you decrease afterload, the heart is able to contract a little bit more vigorously because it doesn't have to pump against as high a pressure. It's like going to the gym and taking weights off of the rack and lifting a lighter amount of weight. Your heart's able to beat more strong and more vigorously. And a more vigorous contraction is going to also accentuate the murmur of HCM because of that same physiology of increasing the contractility or strength and vigor of which the heart beats, worsening possible systolic anterior motion of the mitral valve, or that obstruction of the heart muscle into that left ventricular outflow tract itself. So the physical exam maneuvers that we as clinicians will ask our patients to perform that will worsen or make the murmur of HCM louder are going to mimic those physiologic effects: decreased preload and decreased afterload. Physical exam maneuvers like going from a seated to a standing position is going to decrease your preload and worsen the murmur. Similarly, performing a Valsalva maneuver or bearing down like you're taking a bowel movement, but without the bowel movement, decreases preload because of increased intrathoracic pressure that doesn't allow as much venous return to go to the heart, causing decreased preload or decreased amount of blood filling the left ventricle, worsening the murmur of HCM. On the other side of things, there's some maneuvers that can actually soften or decrease the intensity of the murmur associated with HCM. Those maneuvers include squatting. Squatting will increase venous return a little bit and increased preload, which will decrease the intensity of the murmur of HCM. Similarly, the hand grip maneuver increases afterload and decrease the murmur of HCM. For medical trainees, remember that HCM and mitral valve prolapse, those murmurs are tied together, so everything that accentuates the murmur of HCM will also accentuate the murmur of MVP, and similarly, anything that decreases the intensity of the murmur of HCM will decrease the intensity of MVP. For patients, I think it's important to understand the physiology behind this, maybe not the physical exam maneuvers, because the medications we use to treat HCM have the same physiologic effects as all these different maneuvers I just described. So how do we treat HCM? The mainstay of therapy are beta blockers and non-dihydropyridine calcium channel blockers. For medical trainees, remember that dihydropyridines are ones like amlodipine and nifedipine. So the non-dihydropyridines are verapamil and diltiazem. The reason we use these meds is that they decrease contractility, meaning the heart doesn't squeeze with so much vigor and contractility to decrease that obstruction. And similarly, decreasing the heart rate may also help with some diastolic function. In HCM, there is a little bit of an abnormal diastology or diastolic function, or how the heart is able to relax. And this gives the heart a little bit more time to go through its diastolic function and relax in a slower manner, and also hopefully fill a little bit better and increase the amount of preload that the heart's getting. All of which was described earlier with those physical exam maneuvers and has a similar physiologic effect, but over a long term. We can't just have people doing a hand grip maneuver all the time. So first line is typically beta blockers. Second line medications, or sometimes first line, can be verapamil. But what if those medications don't work, or they're not working enough? Another drug that we commonly use is class 1A antiarrhythmic medication called disopyramide. This medication works as a negative inotrope. It directly decreases the contractility with which the heart beats. This drug has to be used with caution in patients with prolonged QT intervals because it can intrinsically prolong the QT interval, which can put patients at risk of VT, VF, and sudden cardiac death. There are other medications that we specifically want to avoid in patients with HCM. These include things that are going to decrease your preload. Noticing a theme? Those are diuretics like Lasix or furosemide, Bumex, or torsemide, or other ones like thiazide diuretics like chlorthalidone or hydrochlorothiazide. Other medications that decrease preload in isolation like nitroglycerin, dihydropyridine calcium channel blockers like amlodipine and nifedipine, and even ACE inhibitors or angiotensin receptor blockers. Sometimes we are forced to use those medications because patients who have HCM can also have other comorbidities. And sometimes we end up actually using those medications, but those are really special considerations and that should be managed by a cardiologist. As healthcare clinicians who are managing these patients, you have to also be very cautious if you're ever using a medication with positive inotropic effect, things like dobutamine or dopamine, which can worsen the physiology of HCM. There are other lifestyle things that we want patients to do. Simple things like staying hydrated, avoiding being severely dehydrated. We also generally advise patients to avoid highly strenuous physical activity. My favorite drug, however, is a new one that is first in its class and the first successful drug that has been proven to be effective in the treatment of HCM. That drug is mavacamten, or the trade name Cameos. This drug was specifically made for patients with HCM, and it's the first one ever made that it's successfully shown that it's proven to be effective in these patients. It was studied robustly in the VALOR-HCM and EXPLORE-HCM trials. And for any cardiology fellows or medical trainees, I highly encourage you to go find those articles and read them yourself. It showed such a robust improvement in clinical symptoms, decrease in NYHA classifications, decrease in intracardiac gradients, or a decrease in how much that obstruction is causing inside the heart, increase in 6-minute walk test, improvement in quality of life. Very new drug, so I'm sure it's really expensive, and it's a very specific indication specifically for HCM, but I'm interested to see how in the next 10 years this drug will impact patients with HCM and how it might change our day-to-day practice of patients with HCM. And perhaps it might be a first-line therapy. But for now, it's a great new drug and it works. So far in the trials, which were relatively short for big randomized control trials, it showed that it was very safe, but we still have to continue to monitor for its long-term side effects in patients with HCM. What we have to remember is that the patients in the second trial were candidates for the next therapy that I'm going to be discussing, which is a surgical myectomy. So this drug helped keep patients from undergoing open heart surgery while still improving their symptoms. So let's say a patient is refractory to all of these medications. What else can we do for them? This is where the badass cardiothoracic surgeons and interventional cardiologists come in. The two procedures that we can perform, the surgical myectomy, which is essentially open heart surgery, and the surgeons scoop out this excessive myocardium, or the extra heart tissue that's excessively thick and getting in the way. Kind of reminds me of when people scoop ice cream out of a big tub. The second option is an alcohol septal ablation. An alcohol septal ablation is essentially where we go in through the groin or wrist, go into the aorta, and down to the coronary arteries. We inject some contrast dye to identify an artery that supplies blood flow to the affected myocardium that we want to get rid of. So instead of open heart surgery, the benefit of this is it's relatively less invasive. The interventional cardiologist inject a little bit of contrast dye and identify some septal perforators. These are branches that supply the septum, or the part of the heart that's abnormally thick. And what they want is an artery that supplies a little bit of myocardium, but not a huge amount. Once they identify that, they inflate a balloon so that they can isolate the area of myocardium that's going to be infected. Once they do that, they inject pure alcohol into the myocardium and essentially induce a heart attack and kill myocardium. For this procedure, it's relatively safe, but it can cause some rhythm abnormalities. And in my experience caring for these patients after they've had this procedure, a lot of them will get a pacemaker that might be temporary, but sometimes it does end up being permanent. For cardiology fellows, it's important to remember that the myectomy is going to cause a left bundle branch block, whereas the alcohol septal ablation will induce a right bundle branch block. So if a patient comes in, whether in real life or on the test, with a left bundle, they cannot undergo the alcohol septal ablation, because if you already have a left bundle, you don't want to give them a right bundle as well. And if a patient comes in with a right bundle branch block, you can't perform the surgical myectomy and induce another left bundle. Just bad news. For patients, it's important to understand that after the surgical myectomy, you're going to feel better the very next day. And that's because we remove the obstruction that can be causing a lot of your symptoms. It takes about a month to still recover from open heart surgery, but with regards to that obstruction, you're going to feel better the very next day. Whereas patients who undergo the alcohol septal ablation, it's going to take a few weeks for that myocardium to die off, get smaller, decrease the obstruction, and for you to start feeling better. So give it a little bit of time. Both of those procedures are perfect for patients with the asymmetric basal septal hypertrophy HCM. Patients who have apical HCM are limited in what we can really perform because we can't perform that alcohol septal ablation on patients with apical HCM. For them, the only therapy that we really have right now is surgery. So here I just want to show you an actual real person who underwent this surgical myectomy for apical HCM. This is the case that I got from YouTube. This was not my patient. So here they're showing you the pre-op TTE, or transthoracic echo, and you can see that this looks like that spade sign with a very thick myocardium in the apex. Now I need to warn you, if any anyone is queasy like my brother, I'm about to show you the actual open heart surgery. So if that is not something you're interested in seeing, just skip along a little bit. This patient is on bypass as indicated by all those wires and tubes on the left-hand side. The surgeon is identifying the apex where they make their initial incision, access the myocardium, and begin to excise this excess myocardium to increase the size of the left ventricular cavity and hopefully decrease the symptoms of this patient. This video just makes me so thankful that there are people in other specialties with other interests in medicine, because I certainly would not want the responsibility of opening someone's chest, removing part of their heart, and then closing them back up. And here's just a beautiful picture of a patient's heart beating. So now let's take a look at the echocardiographic images, pre-op on the top left, post-op on the bottom right. And this is a parasternal short view, so we're looking at the heart in cross-section, and you can see the pre-op size of the left ventricular cavity is so small, and the post-op is much bigger. And here again is just a different view of that same heart. And if you just look at the inside of this left ventricle in the pre-op top left, post-op bottom right, how much bigger that left ventricular cavity is. Next thing I want to discuss is atrial fibrillation in patients with HCM. If you want more details about atrial fibrillation, I have a whole YouTube video all about it. Go check it out. But in short, for patients with HCM and concurrent AFib, we ignore the CHA2DS2-VASc score, or the score that estimates their yearly risk of stroke, to help us decide on using anticoagulation or not. And every patient with HCM and atrial fibrillation requires anticoagulation. You can use any of the new oral anticoagulants like rivaroxaban or Xarelto, dabigatran or Pradaxa, apixaban or Eliquis, or edoxaban, or the old drug Coumadin or warfarin. Reason for this is patients with HCM are at an exceedingly high risk of stroke when they have AFib, so we just ignore that CHA2DS2-VASc score and anticoagulate them. Earlier in the video, I had mentioned myofibril disarray, or that abnormal deposition of the heart muscle cells that can increase the amount of fibrosis that they have and increase their risk of sudden cardiac death due to an abnormal heart rhythm, like VT or VF. In the past, we placed a lot of ICDs, or implantable cardioverter defibrillators, in patients to prevent sudden cardiac death. Nowadays, we refined it a little bit, but it's still not a perfect science. And for patients, this is a discussion that you need to have with your cardiologist and weigh the risks and benefits of placing an ICD and sudden cardiac death. No procedure and no device is without intrinsic risk, but certain patients in HCM are at exceedingly higher risk of sudden cardiac death than others. On the screen here is an image from a JACC article that shows some major clinical indications for ICD. The big ones that cardiology fellows and patients should be aware of is a family history of sudden cardiac death, or a personal history of sudden cardiac death, extreme LV hypertrophy, that's an LV wall greater than 30 millimeters, which is real thick, unexplained recurrent syncope. Basically, some people can pass out, and if we know that it's because they were dehydrated or they had a vasovagal episode, we don't have to put an ICD in them. But if a patient keeps having syncope and we're not clear of the underlying etiology, it makes us concerned that it could be a deadly arrhythmia like VT or VF. Obviously, these patients might have a monitor on them, like a Holter, an extended Zio patch, or even an implantable loop recorder, which allows us to look at all the different rhythms that a patient has and records it over a 5-year period. And if we see that there's a reason why they're having syncope, which is a fatal arrhythmia like VT or VF, then we're going to put an ICD. But even so, if a patient is having recurrent syncope, we have to look and consider doing an ICD. Another indication is an LV apical aneurysm. I'm going to pull up an image here, and essentially what you have to understand about an apical aneurysm is that if you're having that mid-cavitary obstruction, blood isn't able to get out, but if there's already blood in the apex, it's got to go somewhere. Often that pressure ends up going backwards, and that increased pressure can damage the heart over time and actually cause this aneurysm to form, which is dead myocardium and can also increase your risk of sudden cardiac death. One of the more interesting ones moving forward is LGE fibrosis, or late gadolinium enhancement, seen on cardiac MRI. Gadolinium is a contrast agent we use specifically for MRIs. When we perform a cardiac MRI on patients with HCM or many other conditions, late gadolinium enhancement indicates that there's dead myocardium somewhere. So if we see a lot of LGE, or late gadolinium enhancement, it indicates that this contrast dye is leaking out of the cells because they're dead and going towards areas of dead myocardium. If there's a lot of fibrosis, it might push us towards or away from placing an ICD. Generally on the guidelines, it says about greater than 15% of the LV mass, either alone or in association with other risk factors, that might be a likely source of ventricular arrhythmias. And it's another tool that we have to help us better understand what's a patient's risk of sudden cardiac death. For cardiology fellows, the echo diagnostic criteria for HCM is asymmetric septal hypertrophy greater than 15 millimeters, or a septal thickness to posterior wall thickness ratio of greater than 1.3. On the screen here, I also included some other echocardiographic imaging findings that you should also look for in patients that have known or suspected HCM. Last thing I'll mention for patients is screening. If you are diagnosed with HCM, talk to your physician about having your first-degree family members, parents, siblings, children, getting screened for HCM. There's a little bit of a difference if you're diagnosed clinically with HCM, but with a negative genetic screening, your family members may suffice to just get an echo. But if you are deemed positive for HCM genetically, then your first-degree relatives should be as well, along with getting regular screening echocardiograms at specific intervals, depending on their age. Last thing I'm going to mention is for cardiology fellows or medical trainees who are interested in cardiology. This is a waveform from left heart catheterization. There's a pressure wire in the left ventricle as well as the aorta. On the top of the screen, you can see the EKG running on the top. There's a normal beat. This next one comes in kind of early, likely a PVC, and then a short compensatory pause followed by a pacemaker spike. The next beat is normal, and then the next one is a PVC, indicated by that arrow with a PVC, that short compensatory pause, and then a normal beat. So now let's just take a look at the pressure waveforms from those three beats, where it says PVC, I want you to look at the EKG tracing right before it and after it. So the one before the PVC is a normal beat, and you can see that the LV tracing and aortic tracing are pretty much the same pressure. Then you have this PVC, the pressure wave goes down, and that's what we would expect because the LV isn't able to fill as much, so the pressure isn't going to be as high. That compensatory pause, telling the heart, hey, chill out, let's get everyone back in line, causes the heart to fill up with more blood, increasing preload, but really the effect of that acutely is increased contractility. Going back to the Frank-Starling curve, the more that the myocardial fibers cross-link, the greater that contractility force is going to be. And that is where we see a very specific finding for HCM called the Bruchen-Barough-Morrow sign. Bruchen-Barough-Morrow sign. Bruchen-Barough-Morrow sign. The beat directly after the PVC, after that short compensatory pause, has increased preload, causing increased contractility of the heart. That increased contractility causes LV cavitary obstruction, and you can see that the LV pressure skyrockets and goes very high, but the aortic pressure goes lower. And that's basically showing you hypertrophic obstructive cardiomyopathy through a pressure tracing in the LV and the aorta. The compensatory pause causes increased preload and increased contractility due to Frank-Starling mechanism, and that increased contractility causes obstruction. That obstruction increases the pressure inside the left ventricle, and it doesn't allow as much blood to leave the ventricle to the aorta, thus causing a decrease in the pressure sensing in the aorta. This is very specific for HCM. And the way that you can tell the difference between this and aortic stenosis is that in aortic stenosis, after a PVC, both the LV pressure tracing and the aortic pressure tracing are going to go up because there isn't this dynamic obstruction. You have a fixed obstruction, so an increase in preload and contractility will cause both the LV and aortic pressures to go up together. Now, I know that was a lot, and for patients with HCM, I want you to know that this isn't your fault. You didn't do anything to make HCM or HCM happen to you. You're going to be stuck with cardiologists for the rest of your life, whether you like it or not. You're going to have a ton of EKGs and echoes throughout your lifetime, but I want you to know that there are medical therapies, possible procedures, and new medications that were previously on the horizon that are in the market right now that might be able to better help you manage both your symptoms and improve your long-term prognosis. So if you or someone you know recently got diagnosed with HCM and this video helped you better understand what's going on with that patient, or if someone asks you, what's HCM? And you don't want to explain it, send them this video. And as always, if there's a cardiac condition that you're interested in or want to understand better and have a cardiologist literally explain it to you, comment down below what you would be interested in learning about, and I'll put it on the to-do list. And if you want to support me, pay off my medical debt, subscribe, hit that bell so you can get notified next time I release a video. And follow, like, share.